The next video will be shown by Dr. Mudit Aggarwal. He is the unit head and senior consultant at Rajiv Gandhi Cancer Institute, Delhi. Could I please have Dr. Mudit?
Good morning, all. Hypopharyngectomy, usually when we say about it, so we talk about postopharyngeal wall, piriform sinus, and postcoid areas. So if you see a lesion of PFS, mostly if it's lateralized lateral wall, then you can go ahead and resect that. Medial wall will have its morbidity because you might have to remove the adenoid, AE fold. So when you go for lateral wall, and it's meant for early lesions only, and exposure is a problem when you go for robotic. So this was first described by Park et al. In 2007. He did cases of PFS, one case, then postopharyngeal wall also he did. And when you go deep down, the deep boundary will be your thyroid lamina, and further laterally you might find common carotid also. So you have to be careful about that. So I will show you one of our patients. Hello. So he is a 51-year-old male who was diagnosed as carcinoma esophagus in 2018. So he was a known case of carcinoma esophagus for which he underwent chemoradiation, followed by a robotic esophagectomy in 2019. And on follow-up, he was found to have a lesion in the epiglottis on the right side. And when we did a PET scan for him, and we could see that a left neck node, on examination, left neck node of around 3 to 2 centimeter with ENE was present, and one more lesion was highlighting up in the PFS. So when we did a DL-scopy for this patient, so you could find a lesion which was small lesion which was present on the lateral wall of the PFS. Apex was free, cords were mobile, and one more lesion on the epiglottis was there. So in this patient, when we are doing a neck dissection, his vagus nerve was involved, so we had to sacrifice the vagus nerve. Along that, superior laryngeal nerve also was resected. And when the word about docking, for when you're doing oropharyngeal lesions, your angulation of your FK retractor and a blade and instrumentation is usually somewhere perpendicular to what you're going to operate. And usually we use a 30-degree endoscope because it gives you a various view which you want to. 0 degree can be used for small postopharyngeal lesions. But when you're doing for larynx and hypopharynx, so the trick is that when you place that blade, usually the longer blade of WO mallet blade is used, or a spatula blade is used, and you have to angulate it up around 30 degrees and then open the mouth. And mouth opening, you should not make it much, otherwise base of tongue will fall in your way. So to compromise mouth opening, you have to work. And patient was tracheostomized, and so you can see how the things are. Your base of tongue is coming in the view after placing the retractor. Your the one instrument I am using hot shears, so you can see the shoulder of that instrument is retracting the base of tongue. And other instrument which I am using is a forced bipolar. So this was a lesion on the epiglottis, so I did a type 1A supraglottic laryngectomy. So all margins were confirmed. Then after that, you can see the lesion very well. It's a small lesion there. So what you do is you mark the lesions, mark the on the postopharyngeal wall, not superior aspect. Then come on the lateral aspect. And as these lesions are small, you do not go for full thickness resection of the constrictors. You only have to take a few fibers of superior constrictor. So laterally you come down, and medially because lesion is placed on the lateral wall, so medially do not resect the AE fold. You just have to put a incision over it, and the mucosa and submucosa over the adenoid needs to be removed. So you have to keep visualizing, because now the last cut would be when you go to the piriform apex. So you come on the posterior pharyngeal wall, I'll just fast forward it. So this has to merge with the lateral wall of, that is the thyroid lamina, inner lamina of thyroid cartilage. So this is the medial cut. You can see the lesion there, and then inferior cut is given here, and then you come over the thyroid lamina. So you can take out the perichondrium over there, and this forms the base. He had another lesion on the right AE fold also, that also we resected. So he had a 3 primary in the pharyngeal area, Laryngo-Pharyngeal area. So that specimen is removed, oriented, and it came out to be N3B, PT1. He was deconvoluted on 11th day, and rice tube was removed on 29th day. And this is follow-up DL-scope. You can see left cord is paralyzed, left PFS is not opening up, right PFS is opening up.
His arm, also, yes, on.
What all can you eat?
I can eat mostly anything, but not too much.
So can you eat rice?
Yeah, I can eat rice and soup, noodles, like that. Meat also.
Yes, but
Tell me the name
And sauna.
and what all things you can eat.
I can eat anything.
You are doing your normal work now.
Yeah,
You are doing the normal activity whatever you were doing previously.
yes, yes.
So another patient of ours who had radical radiation for posterior pharyngeal wall lesion and underwent tracheostomy and rice tube insertion there. He was from Northeast, and on 4th month the PET scan was done, which showed that the residual lesion is there on the posterior pharyngeal wall, going close to PFS, and a node was there on the level 2. So he underwent a radical neck dissection on the left side, and it was more on the left side. And we did a transoral resection for this. And same technique, you first start from the superior end, then go lower down. And in this, we did a full thickness resection of the constrictors, as it is a deep infiltrative lesion. So we went to the prevertebral fascia here. All around you go. So here, when you're doing this kind of resection, one needs to be watchful about the common carotid which might come on the way. So you have to keep rotating your camera as well as your specimen to go to the lower limit, because exposure will be challenging in these cases. Right side, left side. So you can see here, this carotid, its pulsations are there here. So you have to leave fibers of constrictor over here. So the specimen is similarly, you have to go and cut inferiorly. So sometimes it might happen that your both instruments are not going. So your assistant has to help you in retracting the specimen, and your one instrument, which is a hot shear, which I am using, this monopolar scissors, will be used for cutting and dissecting the specimen. So no reconstruction was done in this patient. This was left to granulate by itself. And margins, all margins were more than around 4 mm was there. ENE was present. No adjuvant radiation, nothing was given. He was just kept on follow-up. Decannulated on 40th day. Rise tube was removed after 60 days. And after that, he has been followed.
ये आप क्या क्या खा सकता है क्या क्या आप मुंह से ले सकते हैं
अभी हम सेमी सर्जरी
ले रहे हैं
ले रहे हैं।
ऑपरेशन में कितना टाइम हो गया आपका अभी
अभी तो
3 महीना
हो गया।
3 महीना हो गया ठीक है तो अभी आप लिक्विड ले पाता है खिचड़ी सब ले पाता है सेमी सॉलिड टाइप का बना अदरवाइज एक्टिविटी वगैरह सारी नॉर्मल है आपकी
So these are rare cases we do it. Once in a while we get. But challenge is there in exposure. That's what I say. So one has to be mentally prepared when you're doing these kind of cases that you might have to open up. So this is what, and for carotid, if you're having like that, you have to, while doing a neck dissection, you have to cover the carotid also using a PMF. In this, we had used a PMF to cover the carotid to prevent the fistula.